Hey guys, Woodruff here. So we are getting into fractures. And so as a critical care nurse, and especially a critical care nurse who works at a level 1 trauma facility, it is, seeing fractures like this is not that strange for me. But for those that maybe are not used to it, this is what a fracture can look like. And if you are just a super duper smarty pants, you would recognize this is an open fracture, which we'll talk about here soon. But just so you're, as a warning, there's a lot of images in this video that may be disturbing if you're not a nursing student or if you've never seen a fracture and you are a nursing student. But just know if you have a weak stomach, or let's say your significant others, family, friends, child like to watch these videos with you or they're sitting next to you, just know they may be disturbed. I guess I should have said that more about amputation than this one, but it really just depends on what you find more disturbing. But this is something that happens often. Most people at some point in their life break a bone. A fracture is a disruption or break in the bone. And there's like the running joke about like fracture, like, where it's like a person's like, oh, I was so worried that I broke my bone, but my doctor said I just fractured it. And so, yeah. That's the same thing. So a fracture is a break in the bone. Um, the most common reason that people break their bones is due to some sort of trauma or injury, whether it be sports, car accident, or other, crazy adventure. Working in a level 1 trauma, I've definitely seen some interesting fractures. I think because I talk about this one too with like the head bleed section when you get to complex. But I also talk about like, and this is my husband's favorite story that I've told from work. Is this guy that was in a fight with his girlfriend and they were in a moving vehicle and I think they were going somewhere like 40, 50 miles an hour. And he was so tired of having an argument with her that it seemed like a much better idea for him to jump out of the moving vehicle. Um, to avoid the fight, just have to stop the conversation, then to continue it. So pretty much, when he woke up and he was like, "Why am I hurting so much?" And I'm like, "Well, sir, you chose. I want to say you chose violence today, but I should say, sir, you chose to jump out of a moving vehicle, and you have broken, many bones in your body." But amazingly enough, he didn't have that many broken bones, and mostly just, a little bit of brain bleeding. So not, you kind of have to toss up like, what's worse, fight with a significant other, brain bleed. I don't know. But anyway, trauma is a high cause. Cancer can also lead to fractures and then osteoporosis as well, which we'll talk about in the chronic lecture. So like I mentioned, and let me start with this too. If you read in your book and, other schools, it might be different, but, at our school here, the one I teach at least, if you are at my school, we do not expect you to know all the different types of fractures, like Colley's fracture, green stick fracture, all the different types. Do not waste space on your note card. Do not waste brain space trying to figure out everything about the different types of like the different literal like classes of fractures, because as a nurse it's kind of like when we talked about heart failure and other things. Like I'm not sitting there and like and a nurse is like, oh, they have a green stick fracture on their like their left femur. I'm not like, oh, okay, like that's going to completely change my care now, like it's a fracture. But there are certain distinctions that you do need to know. Something that can change my nursing care is whether someone has an open or a closed fracture. An open fracture is like in this picture, the skin is broken, the bone is exposed. I can see the bone. A closed fracture, the skin remains intact. And how does this affect my nursing care? Anytime you see the word open for the type of fracture, you want to think infection. I have opened a portal to straight into my where all of my blood is made and into my body, the bone sticking out. Like there is a entry point for bacteria and other stuff to get into my body. Whereas closed, there's still concerns and things to worry about, but I'm not as worried about infection. So think open. I'm opening the opportunity for infection to get in. So, oh, and by the way, this video is just about introduction to fracture. I'm going to break up fracture because there is a lot of different parts. Diagnostic testing that we're going to do for fractures, usually the highest one or the biggest one that you'll see done is an x-ray. Just to look at straight up bones, one of the best things we can do is look at an x-ray because it's going to tell us what's going on with the bone. If we're worried that there's like blood vessel issues, like flow issues, deep tissue injuries or deeper muscle injuries, then we'll do CT, MRI, but usually an X-ray will suffice. And then we want to look for how they're doing, especially with an open fracture. Like I said, we're going to look for infection, like a white blood cell count. You may not know this, but the the bones, not just one, all of them, are responsible for making your blood cells, and they also house a lot of your blood flow, like a lot of your blood supply. There's something like 60% of your blood supply of your body is housed in your hip bone. And so if you have a hip fracture, especially, or a long bone fracture like a femur fracture, you're going to have a huge chance of bleeding or having blood loss issues. And so that's why, like, if I have a patient comes in and they're like, hey, fractured hip, the first thing I think is bleeding. Like, is this patient bleeding? How are they doing? Are they stable? um we're also going to look for fluid, electrolyte, kidney function issues, because when you have an injury like this, you have a lot of waste, and like from inflammation in your body trying to fix itself, a lot of waste. So your kidneys can get overwhelmed, but you also can commonly be dehydrated or have issues, with blood loss. And so it can lead to a lot of fluid and electrolyte imbalances. So maybe getting a chemistry like a BMP or a CMP, just a basic metabolic panel, that kind of stuff. And then, like I mentioned, when you have muscle breakdown from like an injury, like a fracture, we also check what's called a CK or creatinine kinase. Now, you remember this back from cardiac when we talked about a CKMB. Now, CKMB is specific to muscle breakdown in the heart, but a CK is just general muscle anywhere in your body. Now, when this gets really elevated, what can happen is they can go into that thing we talked about, like with statins, that was called rhabdo or rhabdomyolysis. And what happens there is all the muscle, like all of the waste and the products, the inflammatory stuff, it all bunches together, and kind of pretty much clogs the kidney. So the body's trying to get rid of all these extra waste products and this byproduct of muscle breakdown, and the kidneys get overwhelmed. And then a lot of times these patients end up needing dialysis and having other issues. But we want to see the severity of their muscle breakdown, because this also can help to guide us if we need to give the patient more fluids or something else, just depending. But anyway, you don't have to know that too in depth. And if I don't include, like, you already should know your H&H numbers, you should know your basic chemistry numbers, you should know your white blood cell count. But a creatinine kinase is not something that should be elevated at all. I've seen it crazy elevated, like 25,000 or something ridiculous, but CK is not usually elevated at all. Or like it's not very high. But the higher that it is, the more at risk you are for that rhabdomyolysis. So what are some priority assessments that we want to do? So what does a patient comes in with a fracture? What are they going to complain about? They're going to say it hurts. Pain is one of the biggest things for these patients. We want to do a full pain assessment. That PQRST, what makes it better or worse? When did it start? Blah, 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 blah. That stuff. We're also going to look for changes in their ability to move, bear weight, or function. Because sometimes it's hard to tell if you have a strain or sprain or an actual fracture. But a lot of times the ability to move it, the ability to actually put weight on it is going to tell us, or it has that joint around there lost its function, or the area around it, is it lost its function. Sometimes we know there's a fracture because we can see it. Like there's sometimes, like I get a new admission, it's a car accident, and they've just done kind of the basic, like, once over primary survey of the patient. And so I'm going back through now, and we've taken care of their ABCs. So now I'm starting to get into, like, okay, how's the rest of their body? And we're going to turn the patient. I pick up their arm, and then, like, their wrist is not bending in a way that it's supposed to bend. Sometimes you can literally just see it, or you're like, hey, the bone's not supposed to go in that direction. It can still be closed. It's not even that the bone is out. But a lot of times it's just that, like, something is moving in a way that it's not supposed to. The other thing you might notice, we'll talk about this more later, is what's called crepitus. So sometimes, like, I don't see anything, but I'm turning a patient and I'm, like, holding on to them. Like, I had this happen once with a patient's hip where I was turning them and I could actually hear, like, the bone grating and moving, and I was like, oh, like, so, like, as I was turning them, and I was like, this bone's not where it's supposed to be. It should be making this noise. So it's like bone on bone kind of grating sounds. And it definitely is not a good sound, or a good feeling. It's like a sensation. I could feel, like, the bone grating against each other, where my hand was on their hip. Sometimes you can actually see the break. So there's one time it wasn't even as bad as like that first picture, where I had a patient who, like, I was just looking at their wrist and everything seemed pretty normal. But then when I looked at their wrist, like I could actually see their wrist bone was poking out. Like I could actually see their bone poking out. So that told me, hey, there's a break in their skin. They had an open fracture. You may also notice swelling in the limb. Priority assessments are going to be those neurovasculars, those six. I almost made myself sneeze a little too quick here. 7 P's and 1 C. I was getting a little ahead of myself. So we want to check the neurovascular away from the injury. So if they have a leg injury, I want to check on their foot. If it's an arm issue, I want to check on their hand. And then, like we talked about, their functional ability, what can they do? Because some of these patients, it's like, we're making it seem like these are like life or death injuries for all of them, but some people come in with a fracture and it's like maybe they've had some pain and some swelling and they're like, hey, I'm not sure, this may be broken. And so maybe they're not able to do certain activities or things they once were able to do. The question to ask is maybe, how did the injury happen? Did anything happen recently? I want to get a little bit more of the story behind what's going on. So how do I know a patient with a fracture is getting better or worse? So I know a client with a fracture is better. A fracture is better if their pain is manageable, if they're able to keep a good neurovascular assessment, and no complications is a big thing. Complications are really big with fractures. That's why I'm going to break down the complications, because there's so many of them. Also, if they can complete basic activities of daily living. So even if they have a fracture, are we able to get back to where they can have function and while their bone heals and stuff like that, and find a way around their activities of daily living. They're getting worse if their pain is getting worse, or the interventions for pain are not helping. If I'm giving them pain medicine and they're not getting better, I'll be concerned. If their neurovascular assessment is declining, like they have diminished pulses, they're having paresthesias, or that numbness and tingling, especially like the two of the early signs when we talk about compartment syndrome are pain and paresthesias. We'll talk about those soon. Maybe they're having a loss or decreased ability to care for themselves, like so that they're losing the functional ability. Now that might not necessarily mean there's something wrong with the fracture. Maybe they just haven't kept up with their physical therapy or they need more help. But the biggest things, to know that they're getting worse are going to be signs of complications from the fracture itself and also of immobility. So like, there can be acute complications, like we're going to talk about fat embolism syndrome, compartment syndrome. They can have like general hemodynamic instability, like low blood pressure from the blood loss, that kind of stuff. They could get an acute infection, that kind of stuff too, from the actual injury. Or they can have long-term complications of the fracture, like contractures, mobility issues, foot drop, or they could have, immobility issues like blood clots. They could not be taking enough deep breaths and get pneumonia. So there's a lot of different things. I've only listed a few here. We're going to kind of break them down in the next video, like point by point, because there's a lot of complications with fractures. But yeah, that's the biggest thing is that, maybe they're recovering from their fracture, but along the way, they can have a lot of complications. All right, so speaking of complications, I mentioned a few of these, and this will be the end of this video and I'm going to break the next video. I'm going to go into each of the different, I'll have like one for compartment syndrome, one for fat embolism syndrome, and then one for other type of complications. But like I said, there's more acute ones. Like I worry a lot in the early period about their, stability, recovering from the fracture, making sure they're not having too much blood loss, blood pressure stable, that kind of stuff. Then I'm worried about compartment syndrome and fat embolism syndrome, which we'll talk about. And then, like I mentioned, you can also have musculoskeletal issues where you can have contractures, which we talked about, like with amputation, where their joints get stuck in a certain position, atrophy, which is like I'm not using one limb for a while, so the muscle and everything gets smaller. Foot drop, which we'll talk about, but it's loss of the tone in the foot where it gets kind of stuck in a dropped position. Also blood clots. And then either from the original injury or from being in the hospital, procedures in the hospital, they can also be at risk, or devices, they can also be at risk for infection. So I think that's going to be it. In the next, it's going to be all about compartment syndrome. Hopefully you survived this video. I'll see you for the next one.